Well, good evening, everyone, and welcome to the ALK Positive UK first Zoom Q&A event. And we have about 34 members online at the moment, logged in. So we're very grateful to Dr. Alastair Greystoke for giving up his valuable free time on a Saturday to answer our questions. Dr. Greystoke, for those of you that don't know, is a consultant medical thoracic oncologist at Newcastle University and the Northern Centre for Cancer Care. Alastair, perhaps you could say a few words by way of introduction?
Yes, so thanks very much for asking me to come and talk to you. It's always a pleasure. I'm a great believer in patient involvement in lung cancer. It's great to see such a thriving group. So I've been a consultant at Newcastle for about 7 or 8 years. I first started treating ALK patients when I was training at the Christie. We were running the profile study looking at crizotinib versus chemotherapy. Shows how far we've come in those 8 years. And then when I moved to Newcastle, we were using crizotinib second line. That was the only option we had. I then got involved in the ceritinib studies. So ran the food effect study in ceritinib, which we may want to talk a little bit about. And after that, so I sort of attracted quite a large number of ALK patients in the region into my care for that study. And then when the ceritinib stopped working, I had to start to look for other options for them. So started to look for compassionate access to agents such as brigatinib and then lorlatinib. Also, as Deborah will be aware, I've done quite a lot of work with NICE trying to get access. So was involved in both the alectinib and the lorlatinib appraisals in terms of getting access to those drugs to patients in England. And we can maybe talk about the pros and cons of that process as well as we go forward.
Okay. Thank you very much indeed, Alastair. So just to remind you, the chat facility will be available for the last 10 minutes of the session. So let's get started. And the first question is about alectinib. So one of our members has asked, they're on a reduced dose of alectinib because they had an initial reaction, a rash. Would increasing the dose be worth trying again?
So in general, I think probably not. A lot will depend on, so if the cancer is under control at that dose, I wouldn't normally attempt to dose escalate to go back up the dose again. The doses of the tablets that we use, in general, when we're doing the early clinical trials, we actually often try to push the dose as high as we can. And that's based on when we used to develop chemotherapies, where we used to push the dose higher and higher and higher until, we start to see problems with white cell counts, infections and things like that. And we presumed that the top dose was the best. Now, actually, when you look at the drugs targeting ALK, we may not need to go all the way up to the point where people start to get side effects. And often we don't go quite as far. And so you can get long periods of the drug doing what you want it to do, even at lower doses, okay? Sometimes if at the point that the drug stops working, particularly if it's only in 1 or 2 places, and particularly if it's in the brain, and we can talk about the brain as a potential issue. In fact, I'm sure we will talk about the brain as a potential issue. And if the side effect that you had was not too bad, like a relatively minor rash, it might be worthwhile just pushing it up for a little bit of a period of time and seeing what happens. But in my experience, when you try that, often, even if you can tolerate it, the length of time that it works is relatively small. And you may want to look at changing treatments instead.
That's good. And that will be reassuring for a lot of our members who are actually on a reduced dose as their maintenance dose. So that's really good to hear that actually there's no reason why that wouldn't be successful for them. So thank you very much. So another question we've been asked is, what research would be useful to overcome or prevent the mechanism of ALK resistance? And is there any such research like that taking place in the UK?
This is a biggie. Okay, ALK resistance is a biggie, and I think I'm aware that some of your members will have different levels of expertise than others. So let's start at the very beginning and think about ALK. So the way I think about it is ALK is a switch that shouldn't be turned on. Because of the fusion, it gets turned on, that drives the cancer forward. What we do with the ALK inhibitors, very crudely, is we put a block on that switch. So it's no longer signaling, and the cancer is reliant on that drive that the ALK protein is giving it to survive. It's trying to grow and live in a hostile environment. It shouldn't be able to live there. So if you take away this drive, it dies. And that's why we see when we give ALK inhibitors, you see the shrinkages very rapidly, and often patients feel better very quickly. Okay, so resistance. Resistance can occur in a number of different ways. And ALK is, in my mind, is slightly unusual, and that a lot of the resistance, at least to start with, is driven through ALK. So you see these mutations. So the original event is a fusion, losing control of the protein, but then what you see is mutations that stop your drugs binding, stop your block going into the switch. And that's why, in many ways, and again, I know we'll probably talk about this, you can move, and we have traditionally moved from one ALK inhibitor to the other, and we sort of worked up this ladder of, crizotinib to ceritinib to, alectinib to brigatinib to lorlatinib, which were able to overcome some of those, what we call gatekeeper mutations. And so you're now at the point where with alectinib, brigatinib, lorlatinib, you've actually got very potent drugs that can go into ALK and block it. What then happens is that you're pushing harder on the cancer, and it's going to push back in some other way. So at some point, it stops you trying to become resistant through ALK and starts to do other things to become resistant. And often those are through turning on other switches that are on, that can drive the cancer forward, or by turning on the downstream machinery of ALK. So it's still using the same machinery that the ALK is driving through. It's just no longer relying on ALK. And one of the most common ways it does that, or a very common way we've seen resistance coming forward, is through another gene that's very commonly mutated in cancers, including lung cancer, called KRAS. Okay, and so what you start to see is mutations in other genes. Now, research. So what do we need to know? So the first thing is we just need to get a better handle on how the cancers become resistant. So a lot of the work to date has been done in laboratories. A lot of work to date has been done in America. Some of it, a lot still has been done on circulating free DNA and liquid biopsies, and we'll come on to that. But whether that accurately represents what's going on in the tumor, if you took a lump out of it, is difficult to say. And a lot of it still was done in the setting of either patients who are progressing on the the earlier generation inhibitors, potentially ceritinib, alectinib, or have worked up through those pathways of, ceritinib, crizotinib, alectinib, brigatinib, up to lorlatinib. But is that the same mechanism of resistance to a patient who just starts on alectinib straight off or starts on lorlatinib straight off? Is the cancer still going to become resistant in those ways? So definitely the first thing we need to do is just get a really good idea as to what happens in patients. And is it always the same thing between patients? Almost certainly not. Is it even the same thing within a patient? If you have two areas of cancer progressing in a patient's cancer, are they becoming abnormal in the same way? And again, probably almost certainly not. And so I think that will be the first step to my mind. The next step then obviously is doing something about it, either preventing it or trying to reverse that resistance, and that is going to become more problematic, and I think we'll maybe come on to that as well. So what research do we need in the UK? Well, number one is we need a better idea of our outcomes. So we need to know patients, not all ALK patients are equal. There's different ALK variants. There's some of them will have other mutations and other genes even when they present with their cancer. So how does that impact on treatment in the UK environment? Capture that. How long do you have your ALK inhibitor for? Capture that. How does your cancer become resistant to the ALK inhibitor? Capture all that. And then we've got an idea, then we can start to prioritize what we need to do next and say, well, actually, this is really common. This is the main problem in our outpatients. Let's really focus in on that area. As to what's been done in the UK, I think relatively little at the moment, I'm afraid. And that's, I think partly that's because it's been a really fast moving field. We talked about, I started whatever it was 10, 12 years ago, treating patients with crizotinib. Things have moved so quickly, in terms of the the agents coming through. It's taken a long time to embed. The second, I think, is the perception that but between the Americans and the companies that this is all covered. That the Americans are all, there's some excellent researchers out there, Ross Cabbage, Alastair, who get up in conferences, have got these all singing, all dancing ideas, and you're just like, well, how can you even start to compete with that? And you've got the companies coming through with their big phase 3 studies, and they're collecting all these samples, although whether they're actually analysing them, you don't really know. So I think it's very difficult to think as a UK academic and go to Cancer Research UK and say, well, give me £1 million because I'm going to revolutionise the ALK landscape. And I'll say, well, the Americans or the companies are already doing it.
I think one of the challenges a number of our members have voiced is that we're very grateful that the research is being done in the States, and that's great news because ultimately it will translate to drug availability in the UK. One of the areas that it does preclude us from is around accessing trials when the standard treatments have run out, and I think that's where the big gap is for UK patients. We see that on the worldwide site that I'm sure you're aware of, for ALK patients, and a lot of them, once lorlatinib stops working, they enter into different trials, and there's one at the moment that's being trialed with lorlatinib and a SHP2 inhibitor, for example, and so that's a challenge for our members, not being able to access that. But actually, on that subject of the SHP2 and lorlatinib trial, I just wonder what your thoughts are on any of these trials that are taking place showing a promise for us.
Yeah, I'll just quickly come back to that American thing. So a lot of these trials are being run phase 1, phase 2, so which is establishing the dose and the early efficacy. And that is a problem because more and more they are being done in America, partly because the SHP2 one is slightly different because obviously that's funded by ALK positive, but the commercial studies, they want the American investigators engaged early on. It makes it easier when they're going through to the FDA if it was done in America, and they get the people, it gets into ASCO because it's a big American investigator. Also, traditionally, and this is a problem, UK trials are slow to set up because of the bureaucracy, and they want their trials to run very quickly over a year, and it takes a year to get, we're very good when we got them up and running, we recruit very well, but it can take a year for us to get up. Anyway, sorry, you asked about SHP2. SHP2, I think, is one of the more interesting areas. So SHP2 is sort of what we call an adapter protein. And when I was talking before about some of that downstream machinery, so SHP2 is very involved in the downstream machinery. So ALK is on the cell surface. It's a switch on the cell surface. It needs the signal down through the cell to do something in the nucleus, to tell the nucleus to grow, to divide, to spread, to make proteins that enable it to do all the horrible things we don't want it to do. And so it has to signal down for a series of signals, of which KRAS is one of them. And SHP2 is one of the key proteins that's involved in that process for a number of different switches, including ALK, including KRAS, including some of the other ones that may be mutated. The problem before is it's been one of these proteins, so it's been one of these genes, well, proteins, yeah, that's been very difficult to drug. So it's something that we've been trying for about 20 or 30 years, and we just couldn't get a tablet that worked. But it does now look like there are some really good tablets coming through, and they look to be interesting not only in ALK, but in a number of other cancer types. There's the KRAS mutation we talked about. So I think there's a real drive to bring these tablets forward, and I think the potential interaction with lorlatinib is very interesting. I will be interested to see the toxicity coming through because, I think, lorlatinib is still reasonably tolerated, but it's probably the least well tolerated of the ALK inhibitors, partly because of its potency. And as you start to add in other drugs, that can start to lead to additional side effects. be it either because you're pushing up the levels of lorlatinib in the body, or because you're impacting on two organs, like the liver often might be a problem. The liver has to deal with lorlatinib, it has to also deal with the SHP2 inhibitor. So it'll be very interesting to see the toxicity. But I think the biology is very, very interesting. In mice, for what it's worth, the two drugs work very well together. Whether that will translate to patients, I guess we don't really know, but I think the concept is fascinating. Yeah, one definitely to watch.
Another one that people are talking about is the ALK vaccine. How optimistic are you that that will come through to fruition?
I'm less optimistic about that one, but maybe that's because I've always been slightly worried about vaccines. And I don't know if that's because I'm not really an immunologist. We all know how important the immune system is in terms of dealing with stopping cancers forming in the first place, treating cancers. There has been some very interesting data shown that some patients with ALK lung cancer have antibodies against the ALK protein. Relatively uncommon, but some do. And some suggestion that those patients might do better. And so the question then is, well, can you boost that immune system? So can you give patients who have ALK antibodies, can you use those to try and drive forward efficacy? And if patients don't have them, could you use the vaccine so that patients do produce them? So I think the thing that makes me think that it might be interesting is that there's that little bit of biology, underpinning it. So it's built on an observation of patients, which I always like, rather than mice. The antibody seems to target a different bit of the ALK protein than the switch. So if the cancer is mutating the switch to get around your drugs, well, actually the antibody may be targeting something else. So you're hitting the protein in two different bits. And the third bit is that actually in a normal person, ALK doesn't do very much. So you could have an antibody and it shouldn't cause much in the way of side effects. But, cancers are really, they're sneaky things. And one of the first things they learn how to do is to hide from the immune system. So whether a vaccine is going to be able to get around that, I have slight worries, I have to say.
Okay, thank you very much. I'm not sure that's what our members wanted to hear, but
sorry,
I think we'd rather the truth.
And I'd be delighted to be proved, in 5 years' time. So if you told me 10 years ago that we'd be using the immune system like immunotherapies to target cancer, I would have laughed in your face. I've been wrong so many times. So I'd be delighted to come back in 5 years' time after it's Mark Arwold, who does a lot of this work, gets up and he says, we've got outstanding results in phase 1, and I will happily come back and say how wrong I was.
Okay, all right, we'll hold you to that one then, and hopefully it is an occasion when you're wrong. Okay, I'd like to go back to a question that we've had from someone from again on an alectinib, and I'm going to read this one out. So because I can't remember all these questions off by heart. So my husband is on alectinib, and we were told about numerous TKIs, and that we would move from one to the next. I'm beginning to understand that this isn't the case. Do I understand that lorlatinib would be the next step after alectinib?
So yes. I sort of talked about how it had been a very rapidly evolving field where we moved from, crizotinib to ceritinib as the first, and that was the first second generation inhibitor that we had that came through. And then alectinib came through, and ceritinib had some issues, and it's basically blown away. And I'm not going to spend too much time talking about it unless anyone wants me to, because its share of the market is basically gone. And then alectinib came along and first did a trial in post-crizotinib, but then did a first-line study against crizotinib. So half the patients got crizotinib and the other half got alectinib. It was a study called ALEX, and it basically blew the market away because the length of disease control in that study was far better than had ever been seen, but with crizotinib or ceritinib. And I can remember I was standing in ASCO listening to it. Everyone was very impressed, and actually an ALK patient got up at the back of the room and said, "Look, I'm an ALK patient. This means the world to me to see these trial data coming through," which was great. So that's then basically when it became available in the NHS has come to dominate the market, although brigatinib is now recently been made available in the first line setting. So then the question is, well, what do you do when you progress on alectinib? And so lorlatinib has lots of data, both preclinically but also clinically, mainly in small cohorts, showing that it works in patients who have had multiple lines of ALK inhibitors before, including alectinib. So their trials, they included 20 patients that had one ALK inhibitor, 20 patients that had two. The numbers aren't right, but that's sort of order. 20 patients that had three, 20 patients that had four ALK inhibitors. Basically showed that the number of patients whose cancer shrunk was all about the same. And the length of time that the cancer shrunk for was all about the same, regardless of how many ALK inhibitors you'd had before. And that subsequently has driven NICE to make lorlatinib available in a post-alectinib space. But she's quite right that unfortunately there is nothing else that NICE have approved that will, in terms of TKIs, after alectinib. And you know, one of the questions is, so you've got alectinib and brigatinib that have relatively similar first-line data. Is there any benefit in moving from one to the other? And the short answer to that is I don't know. I've done quite a lot, as I mentioned, of crizotinib to sunitinib to brigatinib to lorlatinib. I haven't had many patients that have gone alectinib to brigatinib or vice versa. There's not really very much data out there that I've seen. And I'm not sure how effective that would be, but certainly in NICE, that's not allowed, and it wouldn't be funded either way to go from alectinib to brigatinib or vice versa. The only time it would be funded is that NICE have this sort of 3-month rule, which I actually quite like, which is to say you can have 3 months on a tablet, and if you're really struggling with toxicity, as long as your cancer's not progressed on it, your oncologist can switch you to another one of the first-line options. So if you start on alectinib and you're struggling with your rash, rather than dose reducing or something like that, you could actually have switched to brigatinib if both are available.
Okay, and looking at trying to space things out, is there, you know, what are your thoughts on maybe adding in chemo or radiation when you get progression on alectinib before you move over to something like lorlatinib? What are your thoughts on that?
Yeah, so okay, I think there's a number of different issues there. So let's talk about radiotherapy first in terms of rescuing the length of time that you're on a tyrosine kinase inhibitor. So if you have what we describe as oligoprogression, which is that your cancer's all shrunk down, is working everywhere, and then one or two areas start to come up, then definitely the advice should be, if at all possible, you should do something to those areas of disease to try to extend your length of time on that tablet. Okay, even if you've got the tablet as another option. Now, well, do we have evidence for that? That's challenging, but I think we all think that's right. Okay, so there's a number of questions that then leads on to. So, okay, it's one or two areas of disease. Well, what about if it's 3 or 4? What about if it's the brain? What if some areas haven't shrunk down? You know, what about if it's 5 or 6 areas? So that then becomes very challenging to work out what the right thing to do is. What about if your local therapy is going to cause quite significant side effects? Is it still the right thing to do? So there is a study running at present time called HALT. So this is okay. No, I'm going to go back a second. So in terms of radiotherapy, there is what's called the standard external beam radiotherapy, where you can give pretty high doses often over a number of different treatments. Sometimes, if you want to get decent doses in, sometimes 1, sometimes 4, sometimes 5, sometimes 20. And that certainly can be enough to kill cancer cells in that area, but certainly setting them back a long way, which is, I guess, what you're trying to do in this scenario, trying to knock them back, okay, because you want to get longer on your tablet. There is now this concept of what's called stereotactic radiotherapy, and I suspect a number of your members may have experienced this, particularly when we're talking about the brain, which again we might come back to. it can also be used in other areas of the body. And what it is very tightly focused, very high levels of radiotherapy that you hope are high enough to definitely kill the cancer cells in that area. But that it does have limitations in terms of the size that you can deliver to, you have, and where you can deliver it to, because you're giving very high doses. And if there's a normal organ close by, you could do permanent damage to it if it gets radiotherapy. Okay. This is one of the areas of technology that is becoming increasingly used in the UK, and one of the things that the government is investing in. But it started off very much in specialist centres, and there's a wide range of expertise in the country. So I guess we may talk about postcode access later on, but the different centres will have different expertise in using these technologies. And also it's very expensive. It takes a lot of time and effort to even treat one area, because a physicist has to sit down and work out exactly how they're going to get all the dose into that area of tumor without anywhere else, without hitting any other organs. Okay. So it is an increasing area. The reason why I'm talking so much about it is there is a trial at present time in the UK, which is sponsored by Cancer Research UK, which your members may be eligible for. And that's what's called the HALT study. And that says that if you have had a response to your tablet and you are progressing in some areas of disease, you can have stereotactic radiotherapy to those areas of disease. But it is a randomized study, so only 2 out of every 3 patients get the stereotactic surgery. You don't get to choose, you get told. And the other person carries on doing whatever their oncologist otherwise would do. And outside that trial and outside the brain, stereotactic radiosurgery is not funded in the UK. So if you have a liver met growing and you're an outpatient, you can go into HALT and you could have stereotactic radiotherapy to that liver if you're one of the 2 out of 3. You could have standard radiotherapy to that liver if your oncologist thinks it's the right thing to do, but you can't routinely have stereotactic radiosurgery to that liver. And you can argue about the pros and cons about it, but that's partly because we just don't know how good it is in terms of maintaining how long it will give you on that tablet, what impact it'll have on quality of life, what toxicity is. So that's why we're doing it within the trial. There's a number of centres around, and certainly, well, we're not running at Newcastle, but I've sent 3 patients down to Sheffield, which is our nearest centre, to have that done. Okay, that's a long answer even to talk about radiotherapy. Sorry.
What about spacing out with chemo?
Sorry.
So we talked about, so the other part of the question was, well, could you space out between alectinib and lorlatinib with chemo? Is that an option?
So that's a very good question. I think it's not allowed in the NHS. I think lorlatinib is only if you're chemo naive. It's certainly something I've thought about, because the concern is once you come off lorlatinib, you're then talking about chemotherapy or chemotherapy immunotherapy, and I'm sure we're going to talk about those options as well. And it does sound like a nice idea, doesn't it? You give your alectinib, you stop, become progressive, you kill back some of the more resistant clones, and you get longer from your lorlatinib, because lorlatinib is very effective at shrinking the cancer down, but in general, the period of length you get with lorlatinib is far less than you would get if you with your alectinib, or that if you use lorlatinib first line, because there's been a study there. So I think it's a very interesting idea. How patients would feel about coming off a tablet to go onto chemotherapy when they have another tablet as an option, I don't know. But yeah, equally, I believe the wording, and I'd have to check, and I can check after this meeting or when you're doing your chat afterwards. I think to access lorlatinib, you're not allowed to have had chemotherapy before, but you can probably remember as much as I do in that one.
Okay, right. Thank you very much. When people have progressed, and you've mentioned you've touched upon this in terms of people progressing on lorlatinib and what are the options after that. Some people talk about immunotherapy. I wonder if you can touch upon that as an option for outpatients. Yeah.
So there's 2 ways that an outpatient can potentially access immunotherapy in the NHS. So the one is when you come off your lorlatinib, there is a combination of 4 drugs that is funded in the NHS. And you'll hear this called different things. It's sometimes called ABCP, which I'll explain, or it's sometimes called the Iron Power 150 regimen, because that was one of the trials that was first used. But most clinicians, I think, will call it ABCP. That is 4 drugs that include chemotherapy, immunotherapy, and a drug that targets the tumor blood supply. Okay, so it gives 2 chemotherapies, carboplatin and paclitaxel, and there's some issues of that we'll come back to. It gives immunotherapy and the anti-angiogenic, and then you have, within the NHS, you have 4 cycles with all 4 drugs, and then you can drop down to just the immunotherapy and the drug targeting tumor blood vessels, and you can stay on this for up to 2 years, provided it's working. And at 2 years, the funding stops. So that's the number one way that they can access it. I'm going to come back to that, and I'm just briefly going to touch on the second way, because I would not advise that people do this. But the second way is that you can have chemotherapy by itself. Carboplatin and pemetrexed would be the one most commonly used in England, and then you can have single agent immunotherapy by itself afterwards. That's funded as well. The reason why I would say that I would not recommend that is most of the research suggests that if you give immunotherapy by itself to an ALK patient, the chances of response are relatively low. Having said that, I have had some ALK patients who have responded to single agent immunotherapy, and I know of others that have. Mainly, I know of 1 or 2 who had it as a first-line treatment when people didn't know they had ALK, and they actually responded to it. So, the exception proves the rule or whatever, but in general, I would try and not use single agent immunotherapy in an ALK patient. So going back, but that is there as a funded pathway. The issue about using the 4 drugs. So number 1, the carboplatin and paclitaxel, we're told what doses we have to use. We have to start at top dose. So normally as an oncologist, if I'm a little bit worried about my patient and how they'll tolerate the first treatment, I'll sometimes take like 20% off the first dose of one of the drugs, just see how they go. And then I can always push up. We're not allowed to do that for that regimen. We have to give top dose first cycle, NHS rules. Second thing about it is paclitaxel does make you lose your hair, which can be a big issue for some patients. It does grow back, but it does it can make you lose your hair. Third issue is it takes quite a long time to administer that regimen. The paclitaxel, you need to have quite a lot of pre-meds before, because otherwise you can react to it, and it takes about 3 hours to give. So with all those drugs, it takes about 5 or 6 hours to actually administer that regimen, and that's a long day for a patient. And the last thing is that there's some suggestions from some of the lab work that pemetrexed may be a particularly good chemotherapy for ALK patients, and that's not used in that regimen. You do then have pemetrexed as an option as your next line of treatment. So if the ABCP doesn't work, you can use the pemetrexed in the next line, but you're not using one of the chemotherapy drugs that's thought to be particularly useful in ALK patients by using that quadruplet regimen. So there are issues around it. The last thing to say is that, as I said, it was based on the Iron Power trial, which included it wasn't an ALK lung cancer trial. It was a lung cancer trial, but it included a small number of ALK patients. I think it was somewhere between 10 and 15. So, and this was a 1,000 patient study. So, it's sort of extrapolated from that. So we don't still know quite how well ALK patients do on it. I've had some success with it, but also some failures with it, I have to say.
Okay. Looking at, you made reference earlier on about how the fantastic advances that have been made in a very short period of time in the world of ALK. How do you think treatment's going to change over the next 5 years?
Yeah. So I think probably it's going to be those mechanisms of resistance. I think probably with lorlatinib and some of the new ones coming through, repotrectinib and stuff like that, we're probably as far forward as hitting the ALK space as possible. So I think there's two main things that I can see coming forward. So number one, which I think is the next thing, is going to be these combinations, rational combinations. So SHP2 inhibitors, MET inhibitors, combining, probably individualizing therapy on the basis of mechanism of resistance. The next thing, and I think this may be potentially interesting for ALK patients, is going to be using what's called adaptive T-cell therapies. And that's so immunotherapy at present. What we mean by immunotherapy is so cancer cells produce a signal saying, I'm not here, leave me alone. And all we do with an immunotherapy is we block that look away signal and say to the immune system, go and attack. Okay, so we're relying on your body's own normal white cells to go and attack, and whether they do or not is quite challenging. Increasingly, what we're trying to potentially doing is taking a patient's white cells out, potentially genetically modifying them so that you repurpose them to target ALK, for example, and then giving them back to the patient with a small amount of chemotherapy to sort of make space to get rid of the other lymphocytes. And that's sort of, so some of your members may have heard of CAR T. And so that's increasingly being used for hematological malignancies, where you use it to attack a protein on the leukemia cells because it's hematological malignancies. We're starting to do that in solid tumors. It's more challenging than doing it in hematological tumors for a number of reasons. Getting your new genetically engineered immune cells into the tumor can be quite challenging. Making sure they don't attack the rest of the body can be quite challenging. But actually, again, for ALK, that may not be too bad because, as I said before, ALK doesn't have much of a normal role in patients. So I can see maybe 5 years down the line, it wouldn't surprise me if we have some form of CAR T therapy being tried for ALK.
Interesting. Okay, thank you very much. I'm going to switch back to, I think, a relatively simple question for yourself now. And someone's asked the question. I think those were a few quite taxing questions, really. But looking at what advice you can give on the best foods to take with TKI for maximum absorption. If you read the SPC, especially for alectinib, it talks about taking the tablets with a high fat meal, and I think there's a lot of confusion as to what does that mean? What does that look like?
Yeah, we do food studies with patients sometimes, and they're actually pretty horrible. The stuff that we have to give patients to get the high fat food in. So it's like your fried eggs and your toast with loads of butter on it and stuff like that. As I said, we did the suritinib food study where the poor patients had to do that. They had to, it wasn't your standard bowl of Special K. It was, a couple of bacon rashers, a fried egg, toast, with full fat butter on it. It didn't look particularly great, I have to say. Again, I think it's unlikely that it has a major, the one that I had a major impact on was suritinib, which we did the food study on and found that with food, you could take a lower dose and it was much better tolerated, which is why they changed the label. I think it's hard enough taking the whatever it is 4 tablets for alectinib anyway, without trying to force it down on a bowl of grease. I would go for a healthy, balanced diet. Yeah, don't try and starve the cancer because people. There's some diets out there that are proposed by some people on the internet about not using any sugar or not using any fat because the cancer will feed on it. There's no evidence of that at all, I'm afraid. Our bodies are very good at maintaining, their own blood sugar level, and the cancer is very good at taking the sugar in. But I would just go for eating sensibly rather and not worrying too much about it, quite frankly.
Excellent. That's very reassuring to hear. So, especially from I would say the majority of our members who do try and stay as healthy as possible, and it has come up several times that it's counterintuitive to eat a high fat meal. So that's great. Thank you very much for that one. Looking at another question, which going back to crizotinib, because I know not many people are still on it, but we still have 1 or 2 members that have done incredibly well. And so we've got one member who's been on crizotinib for many years. And if they get progression in only 1 or 2 areas, do you think they'll get treated with radiation, or do you think they would get moved to another TKI now?
That's a very interesting question, isn't it,
Hmm.
actually? That's fascinating. I think it'd still be very tempting to follow first principles, and if somebody is only progressing 1 or 2 areas, you deal with those 1 or 2 areas. There's always been the tendency for people to jump ship to the newfangled thing, but I think actually I would be tempted to stick as long as you can and save. I guess in that situation, that patient can access brigatinib after crizotinib, that is funded. And save the brigatinib for afterwards, because you never quite know what that's going to do.
Great.
I would stick.
Lovely. I think that's our member will be very pleased to hear that. I won't give their name out, but I can see them smiling from here. So that's good news. Okay. Under what circumstances would you recommend whole brain radiation?
I think that this is an interesting one, isn't it? I think it's so. Okay, well, let's go back to, I've mentioned the brain a few times. So let's just go back again to first principles. So brain disease is very common unfortunately, in ALK lung cancer. Why that is, still nobody's quite explained to me, but very common as a site of presentation. Very common, unfortunately, to develop some disease at some point. So the first thing that I would say, and I think you've reflected this in your good practice, is that patients should have their brain imaged and repeatedly imaged, certainly every time the cancer starts to grow. There is some data out there, mostly derived with EGFR mutant disease, that also have problems with the issue of brain disease, that in retrospective series, patients who have had tyrosine kinase inhibitor and stereotactic radiotherapy up front do slightly better than those that have had tyrosine kinase inhibitor plus whole brain radiotherapy up front, do slightly better than those who have tyrosine kinase inhibitor alone. But that's retrospective series, and there's studies ongoing now looking in this area, particularly in EGFR mutant disease. I would not recommend having whole brain radiotherapy up front. And the reason being, A, is that the tablets have got a very good chance of shrinking things down. Okay, including in the brain. Even if you use, even in the old days, crizotinib used to do it, and certainly now we're using alectinib and brigatinib and lorlatinib. They've got very good chances of shrinking the brain, the disease in the brain down. The other thing is that the toxicity of whole brain radiotherapy is not insignificant, and not only in the short term. So in the short term, it's quite fatiguing, but that's fine. Most of your members will be younger and can manage it, compared to some of the other patients who get whole brain radiotherapy. But in the long term, I think it does lead to, it does have impacts on things like memory and level of function if you talk to my patients. And, we are hoping for our ALK patients now that their prognosis will be many years. And I think over time, that potential impact of having whole brain radiotherapy is not insignificant. So I certainly wouldn't use it up front. Ideally, if the cancer is becoming resistant in the brain, we would like to use stereotactic radiotherapy. And that's partly because A, I think it's more effective, you're getting higher doses in, and B, it spares normal brain tissue. There may be times when it is not possible to give stereotactic radiotherapy to all sites of disease. And that can be partly because of where it is, it can be due to further treatments. And in that situation, I think it would be reasonable, certainly, to think about it, okay? But I think it's a decision that needs to be taken very carefully, and it's, I know we might sort of talk about second opinions and stuff like that. It's certainly an area where there is still different expertise around the country, and it's one where you might want to ask the question of another centre before you go down as to whether stereotactic radiotherapy might be possible. Because some places will say, oh, we're only doing 3 or 5 areas of disease. Some areas will say, well, actually, no, we'll treat up to 20 centimetre cubed. Some areas will do, so, there is variation around the country as people get more expertise in this area. So definitely, I would think about that. So I don't know if that's answered the question. I think there are situations where it should be used, but not up front, and not until stereotactic radiosurgery has already been explored as an option.
That's very useful to know, because I know that some of our members have been told they've got multiple sites of progression in the brain, and they have been told there's too many for whole brain. But what you're saying is maybe check that out with a centre of excellence for stereotactic to see whether that is the case or not before progressing with the whole brain.
Yeah, and you don't even necessarily, need to go see them. And often you can just ask for your scans. Certainly for something like that, you can ask for your scans to go to be discussed by them virtually, and your oncologist will send down a letter, send down your scans, and they'll look at them. Sometimes they'll need a better scan done, but often they'll be able to look at them and say, yeah, no, this is fine. Sometimes not. So. The other question that I come across, which I guess comes to this, so if you have multiple ones and it's getting difficult for radiotherapy, and I've had this happen before, and you've got a TKI switch. So you've got your lectinib, you're progressing in 10 or 12 areas in the brain, and you know that with lorlatinib, you've got a good chance of shrinking things back down again. Should you have stereotactic radiotherapy then? I think up to a certain extent, yes, if they can do them to try to maintain the alectinib. Should you have whole brain radiotherapy then? I think probably not. I would go for lorlatinib as still the less toxic regimen. The question then arises, and I think this is a really difficult one, is so there's the 10 brain mets, and they were too big. Maybe not say too many, because I think too many is often too wrong, but too big, or one was too big. You shrink the 8 or 10 down, and you're left with 2 or 3 that you can still see. Do you give stereotactic radiotherapy at that point to those 2 or 3 that you can still see, even though they're shrunk down? Or do you watch them very carefully and hit them the first moment it comes up? And we don't know that answer at all. I think there's increasing, I think there's an increasing rationale to think, well, maybe we should. And I'm certainly starting to talk that over with my brain team. And every time I ask the question, they go, we don't know. And I don't know either. But then you worry that, well, when the lorlatinib stopped working, you're going to go back to them and they're going to say, well, it's too big now. Increasingly it feels like and I'm starting to push them a little bit harder and say, well, actually, maybe, come on, guys, I've done my switch, I've shrunk things back down. What do you reckon? But this is one of the areas where things are evolving very quickly in terms of our knowledge. So it may be another thing in 5 years time that I have to come back and say I'm wrong.
Okay, all right. We'll wait and see. I can't believe how quickly we're getting through time. So I'm going to see if I can ask some quick fire questions. That's always it might be difficult. I might regret that with the answers, but we'll see. I've got here, it says, I'm an identical twin. Will my twin get this disease as we have identical genes? And that relates to another question where they say, how do they know for certain that ALK-positive lung cancer is not hereditary? So there's 2 for 1 there.
We don't think it is. There's no real evidence so far. And the other thing is that because ALK doesn't have much role to play in your normal development when you're an adult, but it's got an extensive role when you're an embryo. And I think if it was abnormal at that point, you'd really be running into problems. So yeah, we don't think it is hereditary. There's some suggestion with EGFR mutants that, we know that certain ethnicities are more likely to get it. There's some suggestion that certain ethnicities are more likely to get ALK. And we're just starting to understand that. But no, I don't think your identical twin will get it. I really don't, and we don't think it's hereditary. Having said that, we've only known about ALK lung cancer for 10 years. I very much hope I won't be proven wrong with this. I don't think there's good reason to think there is, but as far as we know, it's not hereditary. Okay, all right. Because we're running out of time, I'd like to ask, because the question that came up many times is around the question around scans, and the term. So there's a lot of variation amongst our members in the frequency of follow-up scans and which areas of the body should be scanned. So if I can start off with those 2, that would be Yeah. So at baseline, everything, you used to have a CT scan of your chest and abdomen, and I believe you should have an MRI of your brain if you're prepared to accept the knowledge that you will lose your driving license if they find a small insignificant thing. And I absolutely hate that. I have had so many arguments with the DVLA, but I've not won that argument yet. And your members should take that on because I'll listen to you more than I will. And if there's cancer in the brain, it should be then followed up. What you should do next, I think it is more difficult, and there's no right answer. So certainly you should establish response, probably at 2 months. And you should probably establish maximum response, and so do another one a couple of months afterwards. Whether there is any benefit in then doing scans every couple of months after that is more difficult to know, or whether you should wait for symptoms. I think increasingly, if we're saying, well, if there is 1 or 2 areas of disease that are progressing, we're going to treat them rather than doing a switch, then I think there is the argument. The argument about not scanning regularly is you say, well, you wait till symptoms because you're going to stay on your tablet for as long as possible, and you're only going to change if you get symptoms, so we'll do the scan when you get your symptoms. But the argument is, well, if you're saying, well, we're going to look for 1 or 2 areas and we're going to ablate those areas, and I think you do need to follow it more closely.
Okay. Okay. And in terms of what's the some members are asking the question, what's the difference between CT and PET scans?
Yeah. So CT scan is just X-rays, just taking a picture. In a PET scan, you'll get an injection of radioactive glucose, and that will then go to, if a cancer cell is taking up glucose, then it will shine up bright. They normally do a crude CT scan at the same time. It's not got as good resolution to show where the glucose is going. A couple of issues with PET scans are, so number one, your brain takes up glucose all the time, so you can't see anything in the brain. Your liver takes up a little bit as well, so it's more difficult to see stuff in the liver. And if you are on a TKI and it's switching off, then it may, even if it's starting to grow very slowly, it may not take up glucose. Certainly, I've got a ROS1 patient at the moment. We know his cancer is slowly growing on CT scans. We've seen it over about a year, but on PET scans, it's just completely quiet because there's so little activity, so little metabolism going on.
That's interesting, because a lot of people, you don't get PET scans routinely on the NHS, and they feel that that the CT scans aren't as good as PET scans. So that's actually quite reassuring to hear.
Yeah, if you're thinking about having ablative treatment, so normally if you've seen 1 or 2 areas on a CT scan, we will normally do a PET scan, partly to see, well, is there other stuff throwing up? So there's no point, using radiotherapy with its potential side effects going after these 2 areas if on a PET scan you'd find another 5 or 6 areas. Okay, so then I think it is helpful. And but yeah, you just need to be. There are issues with doing it, and routine PET scans. Yeah, they're not funded. Would I find them helpful? I'm not sure I would, quite frankly. They're very useful as an adjunct to CT scans, and I would prefer having the availability to use them when I need to. I sometimes have to cobble up reasons while I need to do one. I know that's just gone online, but anyway, I'll admit to that. But yeah, just doing a PET scan every 3 months isn't going to help.
Okay, right, lovely, brilliant. In terms of following progression, would you recommend a biopsy to look for a mutation, given the current position in the UK?
Yeah, I still think it's worthwhile, even though as we talked, you're basically moving from either alectinib or brigatinib to lorlatinib. So actually, does the profile help or not? There is a couple of reasons why I would say it. Number one, there are rare cases, including I think one done in London, where the ALK changed from a non-small cell lung cancer to small cell lung cancer, and there we wouldn't want to change. We'd want to give you chemotherapy instead. So that's very rare, but it is reported. The other reason is that there have been reports of other fusions coming along. So ALK is a fusion, and as well as having the ALK fusion, the cancer brings along a new fusion, a new switch. And some of these have tablets for. So for example, there are reports, in fact, I've seen one of these of a RET fusion coming along as a mechanism of resistance to ALK. And I had one of these patients myself, unfortunately, several years ago before, but we now have RET inhibitors, and you can sometimes get compassionate access to them. So, or they're even probably not trials, but you might want to think about whether you bring 2 drugs together in that situation. Very challenging in the NHS. I know people will be on the American websites where they chuck things in left, right, and centre for better or for worse. That's very difficult to do on the NHS, and we probably don't have to. That's a pub discussion, and when next year when we can all sit down and have a drink together as to whether that's the right thing or the wrong thing.
Oh, I look forward to that. I don't know who's buying. There's quite a few of us, so
Not me.
it could be an expensive round for you, Alastair, but here we are. I wonder if you could explain to us in terms of tumour markers, what they are and what they're used for.
Yeah. So tumour markers are normally cancer-associated proteins. So they're normally proteins that often they're proteins that we produce as an embryo, but we don't produce anymore when we're an adult. And again, because cancers are sort of reverting in some ways to similar in embryo, they're growing and dividing things. They sometimes start to produce these proteins. So you'll hear the classic one is called carcinoembryonic antigen (CEA), commonly produced by bowel cancers. And there's about 3 or 4 of them out there. CA125, CA15-3, these are all just proteins that shouldn't normally be produced in high levels in your body and can sometimes be produced by cancers. And certainly I spoke to Ross Cavendish a couple of years ago, and he said he checks them regularly on his patients. Most of them aren't known to be excreted heavily in lung cancer. They can be excreted in small amounts. They certainly can be elevated. I have 1 or 2 of my patients who have asked me to check them. I do them. You know, they're cheap. Nobody objects too much in terms of labs, but whether they're actually any use to guide treatment and whether they can actually pick up the cancer growing more. So the reason to do it would be you have your scan and then you're on your tablet and you're watching them every month. And if it goes up, you do another scan. But, you know, are they good enough to do it in this context? I'm not sure.
Okay. All right. Lovely. There was one here in terms of NGS testing, liquid and liquid biopsies, differences and pros and cons.
So liquid biopsy, very easy, very quick. You take your blood, no labs involved. If you send it off to a company, there's a number of them out there, you'll get your results in about 2 weeks' time. No need to go for a biopsy. So very quick. Problems with that, and the other thing is, you know, it gives you a nice up-to-date picture of a global what's going on, not in the brain, but what's going on in the rest of the body. Disadvantages is you need to have enough DNA to pick up, and that's often a problem, particularly if it's only progressing in 1 or 2 areas. You just don't get enough, particularly if it's progressing in the lungs. The lungs sort of act as a bit of a sponge to the DNA, so it's more common that you'll pick it up if the disease is active in like bones or liver. Second thing is it's not as good at picking up fusions as it is at mutations. So out fusions in themselves can often be missed, but if you're looking for something like a RET fusion, you won't pick that up. No, you can't guarantee to pick it up. It's more difficult, it's less sensitive for those. And the last thing is it won't pick up that change from of cancer type. So if you're going from a non-small cell to a small cell, it won't be picked up on liquid biopsy. You have to have a piece.
Okay. All right.
It's also not funded in the NHS at present time. It costs about £3,000 a pop. Sometimes your consultant can get it for free. I can get it for free for about the next 3 weeks, and then I'm not going to be able to get it for free anymore.
Right. Okay, thank you very much. Right, and I think we've just got time for one last question. So I'm just having a quick scan in terms of, here's one that's come up quite a few times because of the differences in treatment availability in the US, because they do non-NICE approved treatment approaches in the US. Is it possible to go to the US to get treatment that is not available in the UK?
You can go, but you'll have to pay for it. It's not going to be funded. So the NHS will very occasionally fund treatments in another country. The classic example was we didn't used to have proton beam therapy for the young kids with brain tumors, so they used to go over to Germany. We now do, so they stay in the UK, but they're not going to fund for you to go over to America, and the costs will be absolutely outrageous. You know, not only the medical costs, but drugs actually often cost more in America. So yeah, you know, you would need a significant amount of money to do that, even to go on a trial, I'm afraid.
Okay, all right, thank you very much. I'm just having a look, and I haven't seen any questions come through on the chat. So I think people have just been too busy listening to you, Alastair. But we have hit 7 o'clock. So I'm going to suggest that we finish here. I'd like to say thank you very much indeed for your time this evening. And I hope that everyone's enjoyed this evening, and we'll hopefully we'll have we've got another meeting in very soon, coming up very soon. But thank you very much indeed for tonight, Alastair. Really appreciate it. Thank you, everyone.